Good morning, everyone. I'm Fatima Hameed. I'm working as a specialty doctor in Bolton NHS Trust, United Kingdom. So we have a specialized preterm clinic in our hospital in which we have done the audit, which is related to the preterm pregnancies and the histories of preterm. And then we have calculated how much we have the preterm births in that time frame and how much pregnancies delivered at term. So the audit is outcome of pregnancies managed by the preterm clinic. So I'll give a bit of a background. So 53,000 babies are born prematurely each year in UK. In 2021, 7.6% of births are preterm, which was an increase from 7.4 in 2020. So Northwest Manchester has updated a preterm guidelines and to start the specialized preterm clinics in their hospitals. Preterm birth is a major cause of perinatal mortality, as we all know. Since October 2021, there is a standard operating procedure outlining the operational management of preterm clinic for women who have been identified as being at increased risk of preterm birth and labor and during their booking appointments. These women are seen at a specialist clinic from 16 weeks till 24 weeks. The SOPs is planned to be reviewed every 3 years. And there's an incentive government has started, which is called Saving Babies' Lives. And they want to reduce the preterm birth from 8% to 6% by 2025. So I'll quickly go through some of the referral criteria which we have in our Gynec guideline and then the management, and then we can go to the audit findings. So for the referral criteria for this clinic, there are two categories of the patients, high-risk patients and then intermediate-risk patients. So for high-risk patients, anyone who had previous use of cerclage in previous pregnancy, obviously, history of trachelectomy for cervical cancers, they would be referred in between 10 to 12 weeks. Then anyone with history of preterm births or any midtrimester losses, previous preterm pre-rupture of membranes less than 34 weeks, or anyone with intrauterine adherence, Asherman syndrome. History of significant cervical excision, more than one LETS procedure in anyone, or any knife cone biopsy. Anyone who has a known uterine variant like unicorn, bicornuate uterus, or a uterine septum. All these patients need to be referred and they were seen at 16 weeks. Then we do further risk assessment based on their history and examination, and then we come to the management of these patients. Then are the intermediate risk patients, anyone who has previous delivery by cesarean section at full dilatation. So they came at intermediate risk. Then those patients who have one LETS procedure done where the depth of excision was greater than 10 millimeter. They were referred at 16 weeks as well. Then we do their transvaginal cervical scans between 18 to 22 weeks, and then we assess their cervical length and manage them accordingly. So this is a quick review which we have in our guideline, how we diagnose preterm labor and then how we treat it. So first we have to take, if anyone coming in triage with the signs and symptoms of preterm labor, we do a detailed history. We use the Quip app. I think everyone should be aware of that. We use Quip app to diagnose how much risk they are of having preterm labor. We add symptoms, quantitative fetal fibronectin, and cervical length in that Quip app. So if anyone who is diagnosed as preterm labor, what we need to do? We can use steroids, magnesium, and antibiotics, and it is specified to the gestation. If someone who is less than 34 weeks, obviously, then we can use steroids. Preferably 24-hour to 7-day is the best time. We can use magnesium for them for neuroprotection if it's anyone who came with less than 30 weeks, or can consider in between 30 to 34 weeks, 33 plus 6 weeks. It should be given. A patient should have that magnesium for more than 4 hours and within 24 hours. Antibiotics should be given to every patient who came with preterm labor or preterm rupture of membranes. Optimizing place of birth, that any hospital with level 3 NICU settings, should this patient be transferred there in utero transfer, anyone who is less than 27 weeks, singleton, or less than 28 weeks, multiple, or with an estimated fetal weight of less than 800. If any of these maternal interventions are not achieved before birth, then the opportunity for benefit is lost for them. Okay, so I'll quickly go through my audit. So aims and objectives of my audit were, we have to check the compliance with the current guidelines. Objectives were we reviewed the patient cases which were booked in preterm clinic in a specified time period. The standards were we used the audit against the standard outlines in the Gynec guideline, and we use NICE guideline as well to compare both of them. And then we have established a pro forma and filled the data in that. The audit criteria we used these things as a criteria. We checked the risk for preterm labor. All those patients who have been reviewed and referred at 16-week, lower vaginal swabs for everyone, midstream urine for everyone, antibiotics given if they are indicated with MSU. Does they have history indicated cyclogest? Does they have history indicated cerclage? If they have been advised for that, have they taken that? If cervical length is less than 25 millimeter, cerclage or cyclogest has been discussed with them or not. Scan indicated cyclogest and scan indicated cerclage. What is their gestational age at delivery? Their mode of delivery, signs, symptoms of preterm labor have been discussed with them or not. Then advised to contact triage if they have any signs or symptoms of preterm labor. And then have we given them the advice then when the cerclage need to be removed. So methodology was a retrospective audit. We look at the patient's notes which were referred in the preterm clinic. We use the hospital numbers. We done the audit at 50 patients. Data was collected from the patient notes and then input in the pro forma and then Excel sheets. So we'll start quickly with the results now. So we have seen that in the age group, most of the patients, 60% came under the age group of 25 to 35. Only 6% are the people who are less than 25 who go into preterm labor, and more than 35 age group comes under 34%. Then in risk factor, the most prominent risk factor is the history of SHROM, which came as 32% plus preterm labor. Both of these are the most identified risk factor, 24% and 32%. These are all come under one heading as history of preterm births. Then 20% is the patient who have history of LEDs or cone biopsy on their cervix. Then are the other combined risk factor who have a previous cerclage or who have anomaly in the uterus. So we have reviewed all these patients, 96% in the clinic. Only 2 patients, 4%, have not been reviewed as they didn't attend the clinic and they DNA'd themselves. All the 48 patients, their lower vaginal swabs has been taken. Midstream urine has been taken for all these patients, and if anyone was advised antibiotic for either lower vaginal swab or midstream urine, they have been given antibiotic for that reason. So the results were 32% patients were history indicated cerclage and they have been given that, and 26% of patients were history indicated cyclogest and they have been started on cyclogest for that reason. So the results we found according to the gestational age at delivery. So most of the babies have been delivered more than 37 weeks, that is 63%. Only 13% were delivered between 34 to 37 weeks, and slightly less, that is 12%, were delivered between 28 to 34 weeks. 8% of babies are the babies who are delivered less than 28. So overall result, we can see that 73%, 36 patients out of these 50 patients have labors spontaneously. They came in with labor pains. And only 13 patients require iatrogenic interference as induction of labor. 40% of out of these patients have been mode of delivery as cesarean section, and 50% of all patients underwent cesarean but have induction of labor initially and then failed induction and go for cesarean section. So 49 patients, only 1 patient didn't have been given the advice for preterm labor signs and symptoms. Similarly, they have been advised to contact triage if they have any symptoms, any signs of preterm labor. For the advice to give cerclage removal, 22 patients are NA. NA means they have not been given cerclage, so they have not been given any advice. Otherwise, 24 patients who have cerclage, they have been advised that at what gestation their cerclage will be removed. And if they have any signs and symptoms of labor, they need to come and triage and they have to tell that their cerclage is there so that it can be removed. 49 patient appointment attendance. One patient didn't even come to any visit of the clinic. So overall conclusion for our audit was that 2 patients who were not seen in the preterm clinic, then we follow up with their history and everything, we see that they are history indicated cerclage and cyclogist. So 1 out of these 2 patients who DNA'd was delivered at less than 28 weeks, but no intervention was done for that. And the other patient delivered at 34 to 37 weeks. Out of 4 patients who were born less than 28 weeks, all had cyclogist and 3 had cerclage. So despite full treatment in preterm clinic, they delivered as a preterm less than 28 weeks. 66% of high-risk patients had full-term delivery. That's a good. 34% had preterm delivery, of which 24% was spontaneous preterm and 10% iatrogenic. So spontaneous preterm delivery was prevented in 3/4 of the high-risk patient, which we have seen in our clinic. 98% were given verbal and written advice regarding the signs and symptoms of preterm labor and were advised to contact triage if they have any signs of that. So in conclusion, the establishment of such a dedicated preterm birth prevention clinic has significantly improved care in a condensed time frame. Patient feedback and outcome was instrumental in refining clinic operations, leading to an improved information leaflet. Our aim is to continue following the SOPs and guidelines, highlighting appropriate referral indications, and then giving the information to the colleagues, to the junior colleagues, to avoid any unnecessary referrals. The clinic commits to a multidisciplinary approach in refining preterm birth prediction and prevention, aligning with the Saving Babies' Lives Care Bundle started by the government to reduce the perinatal mortality. So recommendations were the same as I have discussed. We need to continue to follow SOPs. We need to follow our local Gynec guidelines. Gynec guidelines are available on the browsers. You can search for them and you can go through them. They have very good detailed history and everything in that. Booking midwives have to take proper history and risk assessment, and they have to refer the patients who are required. Referral should be done according to the high risk and intermediate risk patients so that they can be seen at appropriate times. And then we are aiming to re-audit in 1 year to check the compliance with them. Okay, thank you so much.